This is the sixth presentation for brain neoplasm prepared by Prof. Sharaf and revised by Prof. Rami Edward. It will be concerned with primary lymphoma of the central nervous system, and here this may be associated with immune deficiency diseases like AIDS, post-transplant, and lymphoproliferative disorders. Rarely it may be of the intravascular or dural lymphoma types. Generally, in T1 they are hypointense, in typically hypointense T1, isointense T2, but this is variable. Sometimes it is hypo or hyper, and contrast enhanced T1 typically show high-grade tumors with intense enhancement, while low-grade tumors with absent or moderate enhancement. So enhancement is variable. In immunosuppressed patients, it was observed that lymphoma developing may show peripheral enhancement. Now here, this is first slide for central nervous system lymphoma in an immunocompromised. The contrast enhanced CT show multiple areas periventricular in location, was involving of the genome of the corpus callosum and also involving the subependymal here and there. So it is genome and subependymal, periventricular and periventricular enhancing masses. Notice that they are seen on either side. This is the fourth most common primary neoplasm following glioblastoma, multiforme meningioma, and the low-grade astrocytoma. Most lesions are supratentorial. The differential is for abscesses, metastases, and focal cerebrats. Here, this is a subependymal involvement. It's typical to be seen sometimes in lymphoma. Unenhanced CT shows the disease as a high density in 70% of cases in central hemisphere and mostly enhancing. Of course, there is surrounding edema. In the MRI, the tumor with edema, the enhancing tumor with edema in T1, and this is an example of lymphoma crossing the middle line, enhancing and crossing, seen crossing the middle line. Lymphoma crossing the middle line with edema in T1 with images contrast. Hyperdense masses on either side in CT. In FLAIR, it's iso-intense to the gray matter, but surrounded with marked edema. And in contrast, T1 weighted images, they appear enhancing. So we have edema, we have enhancement, we have hyperdensity in CT, multiplicity, and maybe on either side, and may cross the midline as it is seen here and in this one, cross the midline. Here FLAIR images for lymphoma showing the diffuse edema and the ependymal masses. Subependymal masses and the diffuse edema. involving the geno, involving periventricular regions, both anterior and posterior. Hyperdense CT mass, choroid plexus, iso in the flare, iso to the brain tissue, iso intense, with marked edema, vasogenic type, and it is definitely showing contrast enhancement of the intense type lymphoma. Mass or masses on either side of the midline with marked vasogenic edema, and we have CT as hypointensity. The margin is hyperdense, minimally enhancing. Here is the flare as seen as iso intense to the gray matter to the brain, with surrounding vasogenic edema on either side crossing the midline, while in T1 weighted images it presents as faint ring enhancement of the tumor, which is extending upward into the region of the corpus callosum. This hyperdense mass is seen as multiple masses in flare detected due to edema surrounding, and this is showing enhanced T1 weighted images, ring in the upper part and rather homogeneous in the lower part. Remember that ring enhancement is not a common feature in lymphoma, and it is usually seen in immunocompromised patients. Lymphoma is not necessarily present as mass, but it can present a bizarre appearance like here, inhomogeneous bizarre appearance, and here there is the flare and T1 weighted image, T2 weighted images showing the edema surrounding, and here showing the core as hypointense than the halo zone surrounding. So ring-like solitary masses can be seen in lymphoma, and of course the differential will be for abscesses or cysticercosis. Now here it does not present a mass or bizarre shape, but it presents as if there is an infarct as hypodense area in the CT at the region of the basal ganglia and posterior limb of the internal capsule. In flare there is definite edema, while in T1 weighted images there is faint ring enhancement, and also there is subependymal minimal enhancement. So these are bizarre appearances which can occur as ring or lacunar infarct or tortuous area of enhancement like this one, or ring, and so on. Multiplicity, chronicity, crossing to the other side are among the diagnostic points in lymphoma. Atypical locations may occur as in the midbrain and the region of the infundibular stalk. Here we have mass in T2 weighted images seen as vasogenic edema surrounding a relatively hyperdense area, or in FLAIR it is more evident that it is rather not apparent, it is an iso-intense with marked edema surrounding, while in T1 weighted images the region of the tumor itself is now enhancing, and while in diffusion weighted images it is hyperintense due to restriction. So the appearances of the mass could be iso-intense in T2 and FLAIR, but edema of course will show, and in T1 weighted images it presents enhancement with restricted diffusion in diffusion weighted images. These are the principles. Iso with surrounding edema. This is a mass in T1 weighted image with contrast. Enhancing with surrounding edema. This is a mass as seen in diffusion weighted images showing restriction, and this is a mass in the ADC map showing as negative due to restriction, and this is the cerebral blood flow volume or cerebral blood volume values showing this area to be of decreased vascularity. Rarely we might get a leptomeningeal type of lymphoma, and it shows again restriction on diffusion, and this is the enhancing T1 weighted images, and this is the isoflare with edema surrounding. Leptomeningeal lymphoma. In gliomatosis cerebri, we have widespread infiltration of the neoplastic cells in varying degrees of differentiation. At least 3 lobes of the brain are involved, weeks or years before erupting into full-blown glioblastoma multiforme or anaplastic astrocytoma. Weeks or years. So gliomatosis cerebri, that means infiltration of neoplastic cells which can persist for long time before converting into a full-blown picture of the glioblastoma multiforme or anaplastic astrocytoma. Thank you.